Good afternoon, everyone. Thank you for joining us for this afternoon's plenary session, which is our second one of the day, for what is the role of primary care in the patient's journey through lung cancer. We have an amazing line of speakers. So we'll start off with Dr. Gail Darling. She is a professor of surgery in the Division of Thoracic Surgery at the University of Toronto. She's also a professor in the Department of Health Policy, Management and Evaluation. She is the Kress Family Chair in Esophageal Cancer at the University of Toronto and University Health Network, and also an affiliate scientist at the Toronto General Hospital Research Institute. She holds the position of clinical lead for thoracic cancers and high-risk lung cancer screening for Ontario Health Cancer Care Ontario. She is the esophageal disease site co-chair for the Canadian Clinical Trials Group and is a member of the Thoracic Surgery Oncology Group. Dr. Darling is currently the Secretary of the Canadian Association of Thoracic Surgeons and also the International Society of Diseases of the Esophagus. Dr. Darling is the Editor-in-Chief of Pearson's Textbook of Thoracic Surgery. So I'll hand it over to Dr. Darling to give her presentation.
Hello, my name is Gail Darling, and up until very recently, I was the clinical lead for the lung cancer screening program in Ontario. Lung cancer survival has not really improved over the past 25 years and still kills more people than breast, colon, and prostate put together. So how can we reduce lung cancer mortality? Well, primary prevention is very important, and to do this, we need to stop people from smoking. We can embrace screening to detect early, curable cancer, and of course, we can improve treatment. Just to remind everybody the importance of smoking cessation, this shows the per capita cigarette consumption in the US, which peaked around 1960. Followed about 20 years later by the increase in lung cancer mortality in men, which peaked it again about 20 years later and then has dropped off as cigarette consumption has also dropped off. What are the principles of screening? Well, first of all, we are screening an asymptomatic healthy population. There has to be an effective treatment available, and the screening process itself must have minimal harm. We're going to screen a large population to detect a small number who may benefit. Importantly, screening must detect disease at a curable stage, and mortality must be reduced in the screened population. It is a process. We need to define the population at risk, screening test, and then have an algorithm for management of a positive test. Survival is not the appropriate outcome measure for screening tests. And this is because of a variety of biases, including lead time bias, where the cancer is detected earlier but has no effect on mortality. This was the case with chest X-ray. Length time bias, which is an overestimation of survival because screening detects more indolent cancer. And this may be true in our screening population because we tend to detect adenocarcinoma spectrum lesions. Overdiagnosis, detection of disease that would not cause death of the patient because they die of other causes. Lung cancer is not analogous to prostate cancer in this regard, is lethal. And the only thing that might mean that it might be related to overdiagnosis is if the patient has other significant comorbidities. And lastly, referral or volunteer bias. Those volunteering for screening may not be representative of the overall population. There were quite a few screening trials using chest X-ray. They were universally negative. And after multiple trials and a final meta-analysis, the conclusion was that there was no reduction in lung cancer mortality when chest X-ray was used as the screening test. More recently, there was a large randomized trial of almost 155,000 patients who received chest X-ray annually versus usual care. And again, this confirmed that chest X-ray was not an effective screening tool. The LCAP study took 1,000 asymptomatic volunteers with a relatively minimal smoking history, and they had a CT scan and a chest X-ray at baseline. And not surprisingly, the CT detected more nodules, and in fact, 23% of those 1,000 people had a nodule, of which only 2.7% were cancer, and most of those were stage 1. The importance of this study is that it demonstrated that low-dose spiral CT could detect early lung cancer. However, the real test of whether low-dose CT could be used as a screening modality came from the National Lung Screening Trial. This randomized trial enrolled over 50,000 participants who were randomized to either chest X-ray or CT. They were a very well-defined age group, 55 to 74, and they had a higher smoking exposure than in the LCAP, 30 plus pack years. Former smokers were allowed if they quit within the previous 15 years. This trial was stopped early by the Data Safety Monitoring Board because of a significant benefit identified in the CT arm. And here it is. There was a relative reduction of death of 20% in the CT screened arm. This was followed shortly afterwards by the Nelson trial, which was slightly different in that it employed CT versus nothing, so no chest X-ray in the non-screened arm. And this trial demonstrated a 26% reduction in lung cancer mortality in men in the CT screening arm, and a 39% reduction in lung cancer mortality in women. Based on the NLST, Cancer Care Ontario, the prevention and screening arm of Cancer Care Ontario decided that we needed to embark on a screening program. But prior to instituting the program, they wanted to do a pilot to identify the best way to implement province-wide screening. And so there was some research done prior to the start of the pilot, which included focus groups with smokers and focus groups in Delphi service with primary care providers, as well as literature search. The literature search looked at recruitment methods and basically identified that any active recruitment was beneficial. It should be multi-component, but specific activities should be undertaken to target high-risk populations who were generally least likely to get screened. The focus groups with smokers identified that these smokers felt negative attitudes related to smoking behaviors, both from individuals as well as from healthcare providers. It also identified that certain groups were at higher risk because of higher smoking rates, and these included First Nation, Inuit, Métis, Indigenous, and urban Indigenous communities, as well as individuals with lower socioeconomic and education status. Furthermore, because smoking-related data is not readily available, identifying potentially eligible individuals is challenging. Lastly, with regard to the smokers, they indicated they would be willing to accept the risks or potential harms of screening if informed in advance. Importantly, our focus groups with primary care providers in Ontario indicated that they preferred the Ontario breast screening program model. That is, the primary care provider would make a referral for their patient to the screening program, and the screening program would look after everything after that. Schedule the tests, schedule recall, schedule any further investigations required. Our focus groups also indicated that a lot of primary care providers were not comfortable with the informed consent or participation conversation. They felt they had inadequate knowledge and they certainly did not have enough time. They also had a high level of uncertainty about management of screen detected models. So again, letting the screening program run everything, look after all the details was their preferred model. So here's the schematic showing the key aspects of pilot design. So we need to employ active recruitment strategies, and to do this, we use both provider and public recruitment strategies. We decided to determine eligibility based on the Tamamagi risk prediction model rather than using the NLST criteria, and I'll show you a little bit more about that. We employed end-to-end navigation, so we had a navigator who interacted with the potential participant right at the beginning. The navigator determined whether or not they were eligible, applying the risk prediction model. The navigator also would engage in a smoking cessation conversation if the participant was a current smoker. The navigator would reassess whether the individual understood the process, understood the risks and potential benefits, and wanted to proceed. We had a very robust radiology quality assurance program, including not only the technical aspects of the low-dose CT, but also the radiologists themselves. And there was a CME course for the reading radiologists before they could start reading the low-dose CT scans. Next, we applied the LungRADS management algorithm for management of the nodules. And this was a huge advance over the NLST. The NLST did not have any management algorithm. Someone had a nodule, they were referred to a thoracic surgeon. Mostly they had them removed by a thoracotomy. But based on the NLST data, the American College of Radiologists developed the LungRADS management algorithm. And this allows us to safely follow nodules that have a low risk of malignancy, whereas those with a higher risk get moved on to diagnostic assessment. Now, when a primary care provider refers their patient to the screening pilot, if the person is eligible, takes over all these steps, including referring that patient on for diagnostic assessment if they have a suspicious lesion. Of course, the primary care provider is informed every step of the way. So what is the role of primary care in this process? Well, obviously, to refer their patients to lung cancer screening. And to facilitate this, we developed 2 triage criteria, and they include a patient's age of 55 to 75, with a history of smoking at least 20 years, not necessarily consecutively, and not 20 pack years. With those 2 criteria, the primary care provider can refer the person to the screening program. The navigator would determine if they were eligible or not. We also think it's important for the primary care providers to help support smoking cessation, and providing pharmacotherapy if it's appropriate is very helpful, because at this point in time, the program cannot provide this directly. If the individual is screen eligible, the primary care provider is required to manage any incidental findings, and the radiologist report will call those out. And going forward, the radiologist may also suggest the next step for investigation. If the individual is not eligible for screening, many people were quite upset that they weren't going to be allowed to go ahead with screening. But I think it's important for the primary care provider to reassure those individuals the reason they're not eligible is because they have a very low risk of developing lung cancer. And lastly, for those who are diagnosed with lung cancer, to remind those individuals that it's usually early stage and curable. Now, in terms of the data required to determine eligibility, this table shows the criteria or data required by the NLST, as well as the data required by the Tamamagi risk prediction model. And the data at the top of the table is data that's common to both eligibility assessments. And the most difficult thing to determine is the average number of cigarettes smoked daily. And this piece of information is common to both the NLST as well as the Tamamagi risk prediction model. The additional criteria required by the Tamamagi risk prediction model are fairly easy to determine: height, weight, level of education, whether or not the individual's been told they have chronic lung disease, such as COPD or emphysema, a personal history of cancer, and a family history of lung cancer. Now, this table shows the LungRADS algorithm. So the LungRADS applies a score to the CT, 0, 1, 2, 3, 4A, 4B, or 4X. So when the provider gets the report and the participant gets a report, they'll be told they have a LungRADS score of 2. So LungRADS scores of 1 or 2 have a very low risk of lung cancer, less than 1%. And based on this, they are scheduled for a recall CT scan in 1 year. A LungRADS 3 still has a low risk of lung cancer, but it's between 1 and 2%. And so they are scheduled for a recall scan in 6 months. LungRADS 4 are all a bit worrisome. The 4As are suspicious, and they have a risk of between 5 and 15%. And because of this, they are called back for repeat CT in 3 months. The LungRADS 4B and 4X are very suspicious, and these individuals are referred directly for diagnostic evaluation, with one exception. There are some LungRADS 4As where there's a large spiculated lesion seen, and it has characteristics that make the radiologist think that this is an inflammatory lesion, such as pneumonia. And in those very few individuals, they will be asked to come back in 1 month for a repeat scan. So by following this algorithm, we can avoid unnecessary invasive testing or surgery. So what happened in our pilot? Well, in the first year of our pilot, we detected 28 cancers. The majority of these were early stage cancers, 71%. Whereas in the population of Ontario in general, the patients who have a new diagnosis of lung cancer, only about 30% will have early stage disease at diagnosis. And thus, with the screening pilot, we identified a strong stage shift, and we are confident that this will translate into reduced lung cancer mortality. The risk prediction model, the Tamamagi risk prediction model, had an excellent performance characteristics with a 1.72% detection rate, which is superior to that of the NLST and Nelson. So to summarize, I just want to end by saying that lung cancer screening is a process. It is not just a CT scan. Overall, low-dose CT will have a nodule detection rate of about 20%, but most of these are benign, over 90%. And the rate of invasive procedures required because we use the LungRADS nodule management algorithm is very low. It's 1 to 4%, because the algorithm reduces the risk and the need for invasive testing. We listened to our primary care providers from our focus groups, and they told us to embed smoking cessation, and we did. And we had a high rate of acceptance of smoking cessation counseling of 90%. Unfortunately, not everybody quit smoking, but at least they were receptive. We identified that the risk prediction model is more sensitive and specific than the NLST criteria, and we plan to continue to use it going forward. We also identified that there is variation in interpretation of the low-dose CT scans between radiologists, and some training was required to familiarize radiologists with the LungRADS scoring system, and this is now mandatory for all screening sites in Ontario. We also, and I did not show this data, but we also identified that we were able to retain individuals in the screening program. It's not just a one-off CT scan. You have to come back for the next scan. And importantly, we identified stage shift, even in 1 year. Thank you very much for your attention, and I'll be happy to take any questions.
Thank you, Dr. Darling. That was a very informative overview of the lung cancer screening program in Ontario. I know we've learned a lot from the implementation of the Ontario Lung Cancer Screening Program, and a lot that other provinces can learn from as well. So we're actually going to be taking questions at the very end with all of our speakers. And so I would welcome you to put your questions into the Q&A section of the Whova app. And I'll bring them forward to the speakers here live. So in the next part of our presentation, we're actually going to be walking through Elya's journey and also what signs and symptoms to look out for once you kind of suspect lung cancer in your patient. So Elya Martinson is a mom first and foremost to 3 children, ages 8, 13, and 16. She's worked in the social work field for the past 6 years, supporting families in her community in BC. In April of 2020, right when the pandemic was taking hold, at the ripe old age of 36, she was diagnosed with stage 4 lung adenocarcinoma. So I'll get her to share a little bit of her story of getting diagnosed, especially during when the COVID was just starting to take hold. So Elya, over to you.
Thanks so much, Sarah. Hi, everybody. Yeah, like she said, my name is Elya, and you'll get to virtually meet my father later on, who's going to be presenting with me, as he's also as you can see on this slide, a primary care physician, or was as of last year. And we just wanted to say these are disclosure slides. We have nothing to report. So this is a picture of our family, and there's 2 kind of arrows in the very middle of the picture, one pointing to my dad and one pointing to myself. And this was taken a couple weeks after my diagnosis, before treatment had happened. And this is my lovely family. My children, Cash, Nathan, and Nahani. So a little back history to prior to me being diagnosed. Without going into huge details, the year leading up to my diagnosis would be one I would describe as very tumultuous. Lots of change happened, which resulted in me needing to, relook at how I wanted to support myself and my children. I was divorced that year. I lost 2 children that year, and I had to go back to school full time to be able to support the children that I have living with me. I noticed in August of 2019 that I started to lose some weight. Didn't think much of it. Stress does that. In fact, I probably was a little bit happy for that weight to be going away. By January of 2020, after getting my hair done, my hairstylist noticed that I was losing a significant amount of hair. Also just thought, that probably is stress. I did, I did think maybe I needed to go and talk to my doctor, but those are things that you can do later on. Not a big deal, just a little bit of hair loss. I was noticing in February that I started having this pressure in my chest, and the only thing I can describe it as is feeling like I was being hugged from both sides, so squeezed. It wasn't terrible, and I would actually pretty much forget about it during the daytime, but at nighttime, I would be reminded as it was really difficult to sleep, especially on my right side. So by March, I was only sleeping on my back or on my left side of my body. At this point, I decided I should probably check in with my GP. So that was the beginning of March of 2020. As you all know, that's kind of when COVID started kind of becoming a thing here in Canada. And so that appointment was a virtual appointment. So I called my GP and, said I had this tightness of my chest. She said, okay, went through kind of the COVID symptoms. And I said, that's the only thing that I have is tightness of my chest. And it's been going on for maybe about 3 weeks now. So I don't think it's a COVID symptom. And she said, okay, why don't you give me a call back in a week? And if it hasn't improved, then I'll bring you in for an in-person appointment. Life happened. It was time of final exams. It was time of spring break and COVID. So that week stretched to a month. And in the middle of April, I finally remembered to call my doctor, who said, I said, hey, you said a week, it's been a month. What do you think? And she said, well, why don't you come in? So I did go in later on that week to see my doctor. She listened to my lungs, didn't hear anything in my lungs, but said, let's dot our I's and cross our T's and get you a chest x-ray. I went down right from that appointment to get the chest x-ray because it was on my way home and I already had babysitters for my kids. I did that chest x-ray actually at our hospital, which was super close by. My experience with that was, to me, a little bit humorous. As soon as the chest x-ray was done, the radiologist came out and he said, excuse me, I want you to go immediately down to the ER and I will call down and let them know what's going on. And I said, okay. And he said, no, don't even start walking. I'm gonna get you a wheelchair. We'll wheel you down to the ER. I'm like, because I walked in here fine and I'm having this conversation with you, but okay, if you want to wheel me down, go ahead. So they wheeled me down to the ER. And down there is where I was told that I had a pleural effusion and I would need to be admitted to get that effusion drained. They suspected that maybe it was a result of past pneumonia, as I had no fever, no cough, very I was able to talk fine. They did, to me, kind of humorously question if it maybe I had aspirated anything as I was attending university, and they associated maybe university with over indulging. I said, I'm a single parent, 3 kids. That doesn't happen in my life. So after being checked in and had the pigtail drain inserted into my right lung, I was put upstairs into the COVID ward because they, suspected that although I would be clear from COVID, I had to go up there until my results had come back. While there, I had several doctors, my respirologist visit me, my GP call me, and the hospitalist visit me. When the hospitalist had visited me, she said that some of my blood work had come back just a little bit questionable, and she started asking me about family history with cancer. I said I didn't think I had any. But, having that question be asked, it was a little nerve-wracking. So I immediately called my family, my father and my mother, and asked them, hey, do we have any history of cancer? To, my family's, yeah, of course, there was, fear immediately raised with that question. The respirologist happened to walk in as soon as I put the phone down, and he said, you have no risk factors for lung cancer. You're young, you're healthy, you've never smoked, you're good. I was like, perfect, sounds good. That's the answer I like. He said, however, I also will do my due diligence, and I'll be sending away the fluid for genetic testing. Wonderful. My GP also said, you're doing just fine. The chest, the last slide said chest CT. Me and my dad are doing this together. The last slide said I was sent for a chest CT, and that is where they did find the cancer. I had a tumor in my right lung. I was diagnosed, as Sarah said, with stage 4 adenocarcinoma at 37 years old. I was diagnosed with that while I was at home in my room by myself, no support. It was a rough afternoon.
Elya, for sharing your story of diagnosis. So we're actually going to continue your story after we hear from Dr. Lisa Del Giudice. And we're going to continue on with your story with your dad as well, in terms of your journey through right after diagnosis, your treatment plan, and where you are at today.
Thank you.
So Doctor, thank you for sharing. So Dr. Lisa Del Giudice, she's the Regional Primary Care Lead for the Toronto Central Regional Cancer Program. She's an assistant professor in the Department of Family and Community Medicine at the University of Toronto and at Sunnybrook Health Sciences Centre. She has clinical experience providing routine primary care as a family physician at the Sunnybrook Academic Family Health Team. Her role as the regional primary care lead involves developing and disseminating guidelines for providers and developing programs that will improve patient care throughout the cancer journey. Thank you.
Thanks, Sarah. So I'm going to continue on with the theme of what's the role of primary care in the patient journey through lung cancer. And this is obviously about the early part of making that diagnosis. So the signs, the symptoms, and the risk factors that would present early on. So they may present to your family doctor, they may be patients, they may present to you as respiratory therapists or physiotherapists or some of the other roles that you have in your jobs that you do. So I'm just going to start off. I'm just in the faculty disclosures and what have you. I do work for Cancer Care Ontario Health and the Toronto Regional Cancer Program, as mentioned earlier, as a regional primary care lead. So I do receive a stipend for that. As we know, the organization committee for the Respiratory Health Forum, Health Foundation Forum, went through great measures to make sure that there weren't any biases and to mitigate those biases. And this program has received some financial support, as mentioned earlier as well. And so today we're going to do a few cases just to get warmed up, just to get the idea of how I'll be presenting today. We're going to talk about some of the risk factors for lung cancer. We're going to talk about some of those semi-urgent signs and symptoms that you may encounter in your practice and in your roles. Also talk about how to manage them, because those are the ones that you'll probably see. And then also just remind you about some of the urgent signs and symptoms and some of the emergent signs and symptoms of lung cancer that probably wouldn't present to you, and I'm sure still happen. But I'm sure you may encounter in your careers. So here's our first case. So you're seeing your patient, Mr. JR. He's a 68-year-old retired man, and he retired 3 years ago at 65. He had worked for 45 years repairing large diesel engine trucks. He quit smoking when he retired. He liked to smoke with his coworkers at work, but then once he got home, he had no interest. He smoked about a pack every couple of days, 1 to 2 days, depending how busy or how stressed he was with work or at home, for about 50 years. He lives with his wife. They like to split a bottle of wine each day between lunch and dinner. And he's seeing you today because he's had this nagging cough for about a month. And he thought it was a cold because he also had a bit of a loss of appetite, didn't really feel like eating, and also made him lose a bit of weight. And his wife insisted he come in after he coughed up a bit of blood 2 nights ago. So what are some of the risk factors, signs, and symptoms? So what are the red flags that you already see in this history that should raise a little bit of suspicion to maybe take this a little further and work it up? So just have a look here. And we're going to open up the poll right now and just have a look at the options A, B, C, D, or E. And we'll come back to these later on as well. But
So you can access your poll, click on number 1. So what risk factors, signs, and symptoms in Mr. JR's history, and select the option below. I'll give you a few seconds to do so. So most people are picking, oh, it's changing. So mostly between C and D. So ex-smoker, mechanic, lingering cough, hemoptysis, weight loss, plus or minus alcohol consumption. So those are the most answers.
Great. Okay, move on. So here's your second case. You're seeing 72-year-old Mrs. AB, and she's the one who comes in with right chest rib pain. She reports that pain's also kind of making her feel short of breath as well. She's not really sure. She can't really describe it. She started to feel this pain about 6 weeks ago after she did a funny maneuver in her yoga class. She's pretty sure she pulled a muscle or pulled something when she did this maneuver, that new maneuver in her advanced yoga class. You normally see her for rheumatoid arthritis and diabetes. Both are well controlled with just some oral medications. She's never smoked, but has been exposed to secondhand smoke from her father when she was young, and then got married, and her husband, now her son, smoke in the home. And her only vice is drinking 6 cups of coffee a day. And we're going to move to the next slide. So again, do you see any red flags in this history that have come up? Some risk factors or signs and symptoms that are presenting to you that should raise some red flags? And we're going to open up the poll again.
Please go to question number 2. And I'll give you a few seconds to put in your answers. So most people are picking chest, C. Chest and rib pain, shortness of breath more than 4 weeks, rheumatoid arthritis, secondhand smoke exposure.
Okay. And the last case, you're seeing Mr. YZ. He's a 64-year-old man who comes in with voice hoarseness and difficulty swallowing. He's a contractor who renovates old office buildings. So he does carpentry, plumbing, electrical, some welding and painting. And he's often exposed to asbestos. So when he goes in and renovates these old buildings, he, sometimes has to pull out some old asbestos in the walls. He's never smoked and never been exposed to secondhand smoke. He does have asthma, so he takes Symbicort twice daily for that, and has had pneumonia 3 times in the past 10 years, just really unlucky. His asthma usually builds into a pneumonia where he's been treated for it. And on exam, you hear a couple of wheezes on the left side, and you also feel a left supraclavicular nodule. So again, what are some red flags that he presents with?
So please go to question number 3. And put in your answers for that. We'll give you a few seconds for that. So most people are picking A, hoarseness, dysphagia, carpentry, welding, painting, asbestos exposure, asthma, pneumonia history, wheezes, and the supraclavicular nodule.
Okay, and last but not least, based on these cases from 1 to 3, for all these cases, what would you do next? And this is our last question, and we'll come back and we'll do the answers a little later.
So you can go to the last poll, number 4, and put in your answers. So most people said do full physical exam, measure the weight, order labs, order same day, next day chest x-ray.
Great. Good. So I'm just to give you a little bit of context on where all this came from. We did a systematic review and developed some guidelines in terms of what signs, symptoms, and risk factors presenting to you in your offices or in your practice that should make you a little bit suspicious for lung cancer. So we did the first systematic review in 2011. The systematic review and the guidelines about what to look for were published in Canadian Family Physician in 2014. We did a recent updated version in 2019, so just a couple of years ago. And if you wanted to see these in more detail and read up about them in more detail and what were the studies that these were based on, they are available as a practice guideline on the Cancer Care Ontario website, and I've put that there. And they're also part of the lung cancer pathway, the Cancer Care Ontario lung pathway as well, in less detail. But just thought I'd give you a little bit of context of where they came from. So in terms of the risk factors for lung cancer, what our systematic review showed, up to the most recent, so we had to add some in, was that some of the risk factors include current or previous smoking of tobacco. So those are the ones we already know, including cigarettes, cigars, dry pipe or water pipes. So the bong and vaping is included in that. And that was updated recently in our new updates. Secondhand exposure to tobacco smoke, we've long known that. Interesting, a lot more information has come up about lung diseases, so COPD, asthma, and pulmonary fibrosis also being risk factors for lung cancer. So we're seeing a lot more of this evidence showing up. And then always been known personal or family history of cancer, especially lung, head, and neck, as being risk factors as well. As far as people's own personal health as well, we do see that there are also infections that can be a risk factor for lung cancer. So people who've had tuberculosis or known carriers, especially in the respiratory tract of HPV 16 and 18. Having had previous pneumonia is also a risk factor for lung cancer, and as well HIV as well as a risk factor. But some of the underlying health issues as well that have emerged over the last 10 years or so that have also come up as risk factors include having lupus, rheumatoid arthritis, systemic sclerosis or scleroderma, diabetes, the periodontal disease, and the periodontal disease, interestingly, was more so in women than in men, increased abdominal obesity, and then the dyslipidemia. And it's not dyslipidemia as you would have thought. It's actually the risk factors would be high triglycerides and low cholesterol, low HDL, which was a little bit opposite than what we thought. And this was actually seen in a large study that was done looking at risk factors. As we heard earlier through Dr. Block, we know that low socioeconomic status can be related to increasing risk of diseases, including lung cancer, and the high caffeine intake as well, which was also came up in our most recent iteration of risk factors. Interestingly enough, we actually didn't find an association with alcohol, which we thought we'd see given the high caffeine intake and what have you, but we actually didn't see it in our most recent systematic review and our first systematic review. We all know there are tons of occupational hazards in terms of, or risk factors in terms of developing lung cancer. So any previous exposure to asbestos or other known carcinogens like radon, chromium, nickel, again, occupational exposure to dust or other microscopic particles, so wood dust, silica, diesel engine emissions, such as our fellow Mr. JR, chlorinated solvents as well are risk factors. And there's certain occupations as well, and that's probably related to some of the toxins in what they deal with. So miners, painters, iron and steel workers, bricklayers, and welders. So bricklayers apparently have a high exposure to dust, and especially the silica dust as well. Also unventilated cooking over high heat, in-home burning of coal or biomass, and biomass is wood, straw, grass, or charcoal. So there are places around the world where they do burn biomass for heat and for cooking. And so that does fill up the air in their homes, and air pollution as well. So we know that that's also a risk factor for lung cancer. So what about the symptoms that present? So what we found in our systematic review was that some of the semi-urgent signs and symptoms, so we say semi-urgent because you'll see what I mean about the emergent and urgent ones, is that patients presenting with any of the following symptoms should kind of raise a little bit of a red flag in your mind that could this be suspicious for cancer. So even a single episode of hemoptysis, as our fellow had the other night, new finger clubbing, any suspicious lymphadenopathy, so cervical or supraclavicular especially, any trouble with swallowing, or any features of metastatic lung cancer. So for example, weight loss, focal bony pain, headaches, seizures, anything like that, and any features suggestive of paraneoplastic syndrome. So there are many, but I just put the more common ones like hypoglycemia and hypercalcemia that can happen as a result of some of these lung tumors. Also, this was a recent change that we recently did in our updated systematic review, is that we at first had patients presenting with any of the following unexplained symptoms for more than 3 weeks. Now we kind of dropped that. So if people have risk factors, or if it just sounds a bit suspicious or doesn't sound right, we didn't put a time frame on it. We just felt that there's no harm in working these up and taking these seriously when someone has an unexplained cough, unexplained weight loss or loss of appetite, unexplained shortness of breath, or chest or rib or shoulder pain, any abnormal chest sounds that you're not expecting, such as crackles and wheezes, voice hoarseness, Horner syndrome. And recently what we've added in as well that we're finding is that we do see the complete blood count. We do see changes in the complete blood count as well with lung tumors. So things like high platelets, low hemoglobin, and white blood cells. So coming back to our cases, having heard about our semi-urgent presentations, what I've done is I've put in red here, I've highlighted in red the red flags that came up with our first case. So him being a mechanic, repairing large diesel engine trucks, smoking for 50 years, the nagging cough that's going on for about a month now. He's had a loss of appetite, he's lost some weight, and he's coughed up a bit of blood 2 nights ago. And this was response D. So most of you guys were fluctuating between C and D. So most of you guys got this one. In terms of case 2, our Mrs. AB, she came in with the right chest rib pain, the shortness of breath. There's always something that always throws something in the history when they present us about, the funny maneuver, or they did something, or they caught something that always sort of complicates it, but just, you got to put the whole picture together. She also has rheumatoid arthritis and diabetes. She was exposed to secondhand smoke. And remember what I said about the high caffeine intake. She does drink 6 cups of coffee a day. So most of you actually presented the C response, which I believe didn't have the caffeine in it, but this was the red flags in this case. And in this case, Mr. YZ, who comes in with the voice hoarseness, the difficulty swallowing, having his job, his occupation where he's exposed to dust, the wood dust, the welding, the painting, the asbestos exposures and stuff like that. As I mentioned, the previous history of lung diseases, so asthma, pneumonia, these are things that also have came up in his history and have come up as risk factors. And obviously on his exam, he has the wheezes and the supraclavicular nodule. In terms of how to manage these patients who present, so anybody, it's really easy to order a chest x-ray. And we strongly recommend that happen within 2 working days. So that be, if they can't do it today, if you can't send them today because they've got somewhere to go and they've got to go pick someone up or what have you, or they just, parking is going to expire, whatever, they should really have that x-ray in the chest x-ray within the next couple of days. Whether to jump directly to a CT scan, I don't think at this point in time it merits it, but at a chest x-ray is easy to order. I know that it's easy for me to say because I'm in Toronto, but I'm pretty sure that in the majority of Canada, across Canada, you should be able to access a chest x-ray readily in most areas across the country. So in terms of what to do next, yes, the full physical exam, take his weight, order labs. And the reason why I'm saying the order the labs is at the minimum, at least a CBC and a creatinine in case you need the CT scan, and the CBC, obviously, because you can see there can be some markers there, but you can also throw in some other stuff that may be indicative of some of the paraneoplastic syndromes, so the hypoglycemias, the hypercalcemias. So adding in extended electrolytes and extended lights and sugar, if you're quite suspicious and your gut really feels like there's something going on, that may help you with putting the whole picture together. And obviously ordering the same day or next day chest x-ray, really important. So how to manage semi-urgent presentations. So you're going to get these x-rays that come back, and there's going to be some imaging that's going to show low suspicion of lung cancer, or just your own gut will feel it. So if you see on the x-ray some consolidation, maybe with a little bit of a pleural effusion, and you're suspecting pneumonia, treat with 1 cycle of antibiotics and then follow up with a chest x-ray. Make sure it resolves. That's probably one of the most important things. I've noticed that a lot of radiologists are now automatically saying that in their reports is, suspicious of chest x-ray, follow up in 1 month's time to make sure it's resolved. That's probably one of the most important things that you can do for your patients, is just to remember to do that if there are any abnormalities and you do treat them, either a fusion that you treat with some diuretics, or you treat what looks like suspicious for a pneumonia. Make sure that you repeat that chest x-ray to make sure that it fully resolves. The other thing that might come up, you might actually diagnose TB or an atypical mycobacterium infection. So in this case, refer them to a TB specialist, either respirologist or ID, whatever the best person qualified in your area is. Otherwise, you may find that there may be some new COPD that comes up, or some other benign lung disease like sarcoidosis. Again, refer these on to the appropriate specialist. And other conditions may come up like a pulmonary embolism or trauma. Again, you would treat these as appropriate. So what would come up on a chest x-ray that should make you suspicious of lung cancer? A nodular mass, multiple pulmonary nodules, a non-resolving pleural effusion, mediastinal or contralateral hyaluronopathy, interstitial infiltrates, slowly or non-resolving pneumonia or consolidation. That's probably one of your most common suspicious, not very clear cut, which is why I emphasized that a little bit earlier. And the unexplained elevated diaphragm, if there's a new elevated unilateral side that's elevated, that should, or even both sides, that should be something to cue you in. So what do you do? So one of the things that we've noticed in terms of delays in being diagnosed is that sometimes people are referred to the wrong place. And that can sometimes delay management and delay treatment, and time is of the essence, especially in lung cancers. So make sure that you refer them to a respirologist or thoracic surgeon if you are going to refer someone. Across at least Ontario, but I know also across the country, there are some structured clinical programs that facilitate an organized diagnostic assessment. So some of these places are called diagnostic assessment programs, or DAPs, or diagnostic assessment units, or DAUs, or rapid referral clinics. Those are probably the best places to send these types of patients if you have them available, if they are available to you. And the reason why they're good is because they have navigators. They can fast track diagnostic tests, like whether or not this patient needs a CT or a PET or an MRI or what have you. This is where, or bronchoscopy. This is where you're going to get those done quickly and efficiently. And also the multidisciplinary team approach is always very helpful as well. So some of the urgent signs and symptoms that may still present to you, not that common, oftentimes these often go to other places, but patients presenting with persistent non-massive hemoptysis. So they have multiple episodes of coughing up blood or bloodstream sputum. So you may see those in your practice, and obviously need to be referred on, or if you can and you've got easy access to it and get it readily, a CT chest. Someone with comes in with superior vena cava syndrome or obstruction, so that's with the elevated JVP, some swelling in the face, neck, and what have you. And obviously any patients presenting with abnormal imaging reports that are suspicion of lung cancer. So, and these include the ones that are detected through screening, as we heard about earlier. And these should go on to CT scan if they're not already done, and then otherwise, if you can't get one readily, then refer them on. As far as emergent signs and symptoms, these are send them straight to emerge if they call in or what have you. That's stridor, massive hemoptysis, so that's more than 2 cups of blood, and any new neurological signs of brain mets or spinal cord compression, such as seizure. And these should go straight to the emergency department. I wouldn't even bother trying to manage these on your own. And at that point, they should be referred on emergently to a specialist. Thank you.
Thank you, Dr. Del Giudice. That was very helpful. And if you have any questions for her, please write them in the question and answer or chat, and we will bring them over during our question and answer section. So I'm just gonna shift it back to Elya and her dad, Dr. Brinkerhoff. So continuing on her journey, thankfully she is EGFR positive. So her first line of treatment was targeted drug therapy. This treatment has been truly amazing, and her last CT in April of 2021, just 1 year later, came back with no evidence of disease. Elya has spent the last year at home wearing a new hat as an elementary, middle, and high school teacher, as she is a single parent and decided with her kids it would be in everyone's best interest to do school from home due to COVID and being immunocompromised. She was very involved with Lung Cancer Canada in advocating to follow manufacturers' suggested timeline between doses of the COVID-19 vaccines. Elya has embraced her cancer journey and hopes she's able to bring attention to this stigmatized disease. She has been involved with a grassroots campaign started in the US by Heidi and Pierre Onda, a lung cancer survivor and her husband, called the White Ribbon Project. So you can see the white ribbon behind her in her on her video stream. Elya describes herself as not just a cancer survivor, but a cancer thriver. And Dr. Brinkerhoff, her dad, is a graduate of medicine from the University of Alberta in 1988. He did his 2-year family practice internship at Misericordia Hospital in Edmonton, Alberta. He began practicing in 1990 in Kelowna, BC, where he and his wife Joyce raised 4 children. They now have 11 grandchildren. Dr. Brinkerhoff started 2 group medical clinics in his career, the last being in nearby Peachland. He retired in 2019. He had a special interest in palliative medicine, but had also served on the sexual assault response team from 1995 to 2010. Thank you, Elya and Dr. Brinkerhoff. I'll hand it over to you now.
Wonderful. Thanks again. So to continue where we were at, yeah, I got the phone call while I was at home, as that's how COVID was. So at that point, it had taken everybody completely by surprise, especially the respirologist, who was, you know, kind of the point person on my treatment and getting me diagnosed. There was the fluid that was drained, as I had said previously, was sent away for molecular testing, but it was just more of a cursory thing they're doing. So now it was put on as a rush, as the CT scan had shown that there was a tumor in the lung, as I had said. The CT for brain and bone was requested and was done a few weeks later. I was followed by the respirologist, who did weekly virtual check-ins with me over the phone, where I was very thankful that my dad could be there with me, as I used him a lot to tell me what you know, the respirologist was saying. The respirologist was also staying in touch with me, as I did have that continued pleural effusion, and he wanted to monitor if I was able to manage it, or if we needed to get back to getting me drained again. My first contact in person with a doctor since I was in the hospital in April. So this would have been May 21st of 2020. So it had been over a month since I had in person seen anybody. That month was the longest month of my life, knowing that there was this thing growing inside of me and not doing anything about it, feeling completely helpless, that you know, I was not in any way in control of my life, and not seeing anybody in person. There was a lot of pressure put, I felt, on me to be able to decide, you know, for the pleural effusion, for example, like, how bad is too bad? Like, you know, should I just tough it out, or is that going to make things worse? And if I have a new pain, is that just, you know, in my mind, or is that something that I should, you know, talk with the respirologist about? So that was definitely a very long month for me and my family. And to add a little humor to that, my son had an accident, and it resulted in a flood in our home, which ended up that we had to move out of our home for that month in between diagnosis and actually going to BC Cancer for treatment. So we were staying in an Airbnb. So just to add a little bit more to our plate of COVID, stage 4 lung cancer, single parent, and no home because it was flooded. At my first appointment with my lovely oncologist, Dr. Wadwa, here at BC Cancer in Kelowna, which I'm so thankful we have a cancer center in my city, she did tell me that I was EGFR positive. I didn't know really what that meant, but what she said it meant is I was a candidate for targeted drug therapy. I am currently on the targeted drug osimertinib, or the brand name Giudice. It has been touted as a wonder drug, and that is indeed what it has been for me, a complete wonder drug. It was decided that a day after actually the same day I started the targeted drug therapy, I did have a pleuric catheter inserted, as that pleural effusion was giving me significant difficulty in breathing. I could no longer, in that month from being released from hospital and seeing the doctor, my quality of life went way downhill. I couldn't lay down at all without completely coughing. I had to sleep sitting up in a chair. So they did decide that I would be having a pleuric catheter put in, and that was in for 2 months with drainings 3 times a week. Next slide, please, Dad.
Next slide is not
Next slide is not coming, and technical difficulties. Yay!
Yeah. We'll try it again here. Well, keep going, Elya. The next slide is not coming, so go ahead, folks.
Okay, well, I think it was on to kind of, so from there, I can go with the flow. That's how we do these things. From there, I can say my pleural effusion did go away after the 2 months. Oh, and Sarah's going to share the slides. So the pleural effusion did go away after the 2 months. And I was able to get pleurodeces, which, you guys know what that is. I don't have to explain that. And so today I'm doing very, very well. I can say I'm so thankful that by November, when I had a CT scan done, it showed significant improvement. And by my 1-year CT scan, with my treatment only being the Giudice targeted drug therapy, I was given a CT with no evidence of disease. So I am now about 19 months in and managing side effects of the Giudice, but very thankful to be where I am today.
Thank you. I'll take over. Thank you, Sarah. You could go 2 slides further. Okay, Sarah. Well, I'll
next slide.
Take over.
Next slide. Yes, please.
Oh, next slide after this. Okay.
Yeah, please. 2 slides.
No problem. Is this okay? Right here?
Nope, 2 more. 1, 2. Number 12.
Number 12. Okay. Yep. There we go.
We don't see it changing, but maybe it's changing. So just go ahead, Dad.
Yeah. Thank you, everyone. Thank you, Elya. I will just say this much because I don't have the slides in front of me. Really, as a GP, my knowledge of lung cancer was fairly limited. Of course, we know the association with smoking. I was very much aware of the problem with asbestos. And in BC, we were touted a lot with the problem with radon. But for the most part, that was the long and short of it. Dr. Lisa's presentation was fantastic. I never knew there was an association with high caffeine. But if you go to the next slide, one thing about Elya is right thrown in there in the midst of this, she did have some lymphadenopathy. She never mentioned that, but that I'm not sure that popped up while she was actually in hospital, and it came very quickly. So here's my message now. And I must admit, I think I'm maybe a token of someone who shows as a GP how little I do know. Say that with the chest tightness, it was so good that the GP ordered the chest X-ray right away, and that anybody, even a 37-year-old with weight loss, it deserves a pretty careful systemic review. After seeing the oncologist, Elya used me as a dictionary, and it showed me how even a fairly intelligent, college-educated girl like Elya needed a dictionary or deciphering. How much the GP needs to bring patients in to go over their consults with the oncologists and specialists, because they hear such a small amount, and it's probably spoken to them, but the amount they hear is fairly minimal. Next slide, please. So my main message, and really, I think Dr. Lisa's for her presentation is fantastic, but got to keep an eye on lung cancer for any age group, although it would be rare to Elya's age group. And then cancer can hit any age group, so we have to keep that in mind. And as I've mentioned, those with weak support structures, the immigrants, those experiencing homelessness, the economically disadvantaged, they need a lot of GP care. And I think it's incumbent upon us especially to allow these people a lot of access to us. Next slide, please. And it's never mentioned, it seems, in traditional medical circles, but I just think that Elya and I agree that stress was her main culprit. Apparently, she probably had this mutation from years earlier, but I wonder if the gate of weakness in her immune system was opened with stress. And next slide. So that's my part. Thank you very much.
So I am really, really proud and thankful for the White Ribbon Project. As Sarah mentioned, it was started by a couple down in the United States, and now we have a lung cancer or a White Ribbon Project Canada here in Canada, and that's just a way for us to be able to speak about our stories and presenting like this, like I am today. Just I don't know why I have this. Sorry, but I want to really share my story because I don't want others to be diagnosed at stage 4 if we can. And I'm so thankful for lung screening because I really hope that others can get diagnosed at stage 1 and 2. Although I'm doing well, you will never hear the word yet. I'm still hopeful, but you'll never hear the word yet of being cured if you're diagnosed at stage 3 or stage 4. And I'm sure you guys know that better than me. But, that's something that's always weighing on me and weighing on my kids. Because, I'm just thankful for every single day. And thank you for listening to me.
Thank you, Elya and Dr. Brinkerhoff, and all the speakers we had for today. So I'm going to open it up to some questions now. So if you could come on back on our screen. So we have a few questions. So in terms of risk factors you spoke about, Dr. Lisa, can you speak about why alcohol is not necessarily a risk factor, and caffeine is now newly put on there as a risk factor, and how much caffeine? So if you could kind of expand on that a little bit further. Sure.
So this is based on the studies that are out there. So it might be when we do our next systematic review and we look at every study that's ever been published in the literature about a potential risk factor. It caught us by surprise. We weren't expecting it, but we deliberately looked at the alcohol studies that were done as risk factors, and there were none. They actually came up as null once you accounted for everything else, and you took out any of the noise. So if you took out the noise in terms of alcohol, in terms of smoking or other risk factors associated with it or what have you, the alcohol just didn't seem to pan out. It ended up being exactly the same in both groups, both the cases and the controls that were studied. The caffeine intake, in terms of how much, it didn't really quantitate either. I'd have to go back to the study and have a look. I might be able to do that by the end of this, but to actually go back to the study and look at what that study showed, or those studies, there was actually 2 studies that showed it. I would imagine that it's a dose response type of scenario. So I would imagine the reason why I put 6 cups of coffee in there was I figured that it's got to be at least 3 or 4 per day. And 6 I thought would be for sure, would cover it. So, and what the association is with the caffeine or the caffeine intake and cancer and what that mechanism is obviously beyond me as well. Like it was just something that came up when they studied it in these studies. So yeah, it was, we were taken aback by some of the new stuff that we found, even some of the occupations that we didn't suspect as well that came up in the last iteration. But there were a number of studies that were done between 2009 and 2019 when we did our updated systematic review and looked at every study where that came up. I'll have a look and see if I could find what the exact amount of the caffeine was that they decided on that, but my guess is it's a dose response type of scenario.
Thank
Did
you.
that cover it?
Yeah, that's great. I think we've lost Dr. Darling here, but I'm hoping you're able to answer Dr. Del Giudice. So it's kind of in relation to Elya's case. So for lung cancer screening, it's most often done in those 55 and over with risk factors. So is there anything that can be used as a screening tool, such as genetic testing for those under 55?
I think we're far from it, but we're not too far off of it. I think time goes by pretty quickly. It's also, there's also a lot of ethics that are surround that as well. So in terms of genetic testing and what you go looking for in terms of genetic testing, because some people don't go on to actually develop the disease that they're genetically maybe predisposed to. So the penetrance of being genetically tested. So in terms of personalized health and in terms of, are we gonna be there one day where you're born and we do the genetic makeup and we look to see and do we cure them right from birth? I think it's gonna happen. It hopefully will happen in my lifetime. I think we're getting close to it. But at this point in time right now, we don't have the ethics in place. We don't have everything in place to actually do genetic testing as screening to see if people are going to go on to develop it, because we just don't quite know what causes people to go on to develop the disease, and those that don't develop the disease, even though they have the mutation or they may have the genetics for it. I think being cautious of symptoms. So when we first took on the systematic review of the suspicious signs and symptoms, we didn't have lung cancer screening. It was an idea, it was being tested. And so for us, it's really being conscious of signs and symptoms and working them up and doing a chest x-ray, not for screening purposes, but for anybody who's symptomatic. And you could see the symptoms are very vague. There's no harm in doing it. A simple chest x-ray is easy to get, easy to do, not expensive. And there's so many symptoms that people could present within your practice that would qualify for that. And that would hopefully help identifying patients who have got who are young, who don't meet the criteria of smoking, and 60-year-old and smoker that works with asbestos, that we all think they are, but you can see even just vague symptoms, some vague chest pain, some vague weight loss, not so much. There's a good excuse to lose. So there's always a good excuse for a lot of those symptoms. And so a chest test is an easy way just to discover it and find it.
And on that note, actually, there's a question here about chest x-rays as sort of the first diagnostic tool that you would use. Would there be a role to go right to ordering a CT, for example, before a chest x-ray, or would you always go through a chest x-ray first and then CT for staging?
So I think even if the chest x-ray came back, the chest x-ray is easy to get. You don't have to fight for it. You can walk down the hall, you can go around the corner, really easy to do. So we wanted that to be the first test because of its simplicity and because of how quickly you can get one. So even being at one of the biggest hospitals in the country, if I want a CT chest, it's going to take me 2 to 3 weeks to get a CT chest. Even if in my heart of hearts, I'm thinking there's something not right here, it's going to take me 2 to 3 weeks to get that. So a chest x-ray, I can get it same day. And even if our chest x-ray department, or if our x-ray department is down, there's 3 around the corner that I could probably get my patients to go to. So in an ideal world, if you're super, super suspicious of something going on in a CT chest, i.e. massive hemoptysis, several episodes of hemoptysis over 3 or 4 days, you can probably finagle a CT somewhere if you're really lucky. But I wouldn't want you to rely on trying to get that CT when you can easily do a chest x-ray. Because one of the things that we do recommend is if you're still highly suspicious and there's still lots of signs and symptoms that there still may be something there, even though the chest x-ray comes back as negative, then go ahead and order the CT. Because you'll only be 2, 3 weeks, 4 weeks, and in some parts of Canada, 1 month behind. But if you're still suspicious that there might be something going on, then by all means, send off for a CT. And if it's hard for you to get one, then send them to a specialist who can get a CT quickly.
Mm-hmm. That's great. And are there any policies, protocol standards that can be put in place in primary care practices that would help them detect it earlier and help sort of the screening journey or get diagnostic testing quicker? So if you could just comment on that.
I'm a family doctor by training, so I know how hard it is to follow all the guidelines and all the information that comes out there. So I try and go out there. I try to speak at conferences. I try to speak exactly what we're doing today at a family medicine forum, at primary care today, and what have you, to try and get the word out. I'm competing with many, many, many other illnesses and diseases and stuff. So how much that goes in and out of people's ears, even when they do hear me, or if they don't attend my sessions or what have you. But it was, as we tried to disseminate that information, it was published in Canadian Family Physician in 2014, one for colorectal and one for lung, for exactly that. And we just keep trying to spread the word. And I think that's our best bet, and teach our students as well as they're coming up the wire. So that's the other way we try to spread that word, is as much as we can do to disseminate that information.
Thank you. And the last question, I'll hand it over to Elya and Dr. Brinkerhoff. Through your experience over the last year and a bit, would you say that, what other supports would you say it would have been helpful for your journey, or it would be helpful right now in where you are, such as support groups or any other community supports that you could have accessed that we can think of as community care providers?
Thanks for that question. Yeah, and I guess my interpretation, my journey has been through COVID. So I'm sure things were done better in the past. I just so happened to not have any of those community supports. Absolutely, a support group would be amazing. Something for my kids to attend, to meet other kids that have you know, a parent that has a cancer diagnosis would be so helpful. And I mean, these were things that I asked from the social worker, right, you know, maybe within a week of my diagnosis. And they said, you know, due to COVID, sorry, nothing is happening. They sent me some workbooks in the mail. That was the extent that I got to help. So I think Dad mentioned, and you know, I'm so thankful that I do use him as my dictionary. Every time I get you know, a report back or go see my oncologist, still, other than the very first appointment where my dad was able to attend with me, I've had to go by myself, which is putting a lot of onus on the patient to know what questions to ask, to remember the information that they're told. I try to take notes to the best of my ability, but being able to have a support person always should be, I think, is essential. Having support groups, and if there is none, do like I've done and make your own, find your own. I've now, you know, connected with some amazing people that help me along this journey, and who are more, you know, advanced than me or have had a diagnosis longer than me, and I can lean on them. And that to me has been what's made this all possible. And they've inspired me to, you know, walk my walk and speak my truth. And I think the thing I want to leave with everyone is, if you have lungs, you're at risk for lung cancer. So don't think, oh, you know, that can't happen to me. You got lungs? Yes, it can. So please, you know, do due diligence. And if you're feeling something questionable, check it out. Dad, you want to say something?
Just really quickly, the one thing that the oncologist said to Elya that was helpful is she said, we do have one patient on the osimertinib first generation drug who's gone for 8 years, which was a really powerful, helpful thing. Though the prognosis still remains at 38 months.
Yeah. Yeah, showing a little light at the end of the tunnel, always helpful.
Sure. Thank you so much for sharing your story, Elya, and Dr. Brinkerhoff and Dr. Giudice for an amazing presentation of risk factors and symptoms. I know we all learned so much, even just from today. And Dr. Darling for giving us a good overview of the cancer screening program in Ontario. So we're at time now. So we're going to take a bit of a 10-minute break before your next session. So you can choose between 2 concurrent sessions. Remember to fill out your session evaluations and our overall evaluation for our forum that will help inform us how we're going to plan for our next event. And thank you so much for joining us today. Thank you, everyone.
So I guess we'll sign in again back on WOVA.
On the Whova, yes. Thank you so much. That was wonderful. Thank you.
I know.